On a similar topic as we once heard, surgical planning via tele-health consultation, is it effective for patients undergoing minimally invasive gynecological surgery?
Thank you again for opportunity to present our work. It is the second PowerPoint. Excellent, thank you. Okay, as highlighted by the COVID-19 pandemic, telehealth is increasingly being used in our surgical specialties, including gynecology. And telehealth visits provide an alternative for in-person consultation. However, the inability to perform an abdominal and pelvic exam presents a particular challenge for creating treatment plans in gynecologic care. It's unclear whether a telehealth visit for new patients can inform decision-making for preoperative planning in minimally invasive gynecologic surgery. We sought to determine if the proposed treatment plan created at the time of a new patient consultation concurred with the treatment plan at a subsequent in-person examination. Our secondary objectives were to evaluate perioperative safety and to report the average visit length for patients undergoing telehealth consultation. This is a single-center retrospective cohort including patients who underwent new patient telehealth consultation for a minimally invasive gynecologic practice between March 24th and November 5th, 2020. Telehealth visits were conducted by 2 fellowship-trained minimally invasive gynecologic surgeons and an advanced practice practitioner. The primary outcome was the agreement between treatment plan proposed during the virtual visit compared with the treatment plan proposed during the inpatient or in-person consultation. The treatment plans consisted of either conservative or surgical management, and if the treatment plan remained the same, it was considered concordant. Conservative management was defined as expected management, treatment with physical therapy or medications, including hormonal, non-hormonal, and pain medications. Surgical management was defined as treatment with any operative intervention. Secondary outcomes were collected from the EMR after the 30-day postoperative timeframe, documenting intraoperative and postoperative complications, and visit duration was obtained from billing documentation. 158 patients completed a new patient telehealth consultation, and 115 of those completed an in-person follow-up encounter with a return rate of 72.8%. Patient demographics and baseline characteristics grouped by treatment plan created at the initial telehealth visit are shown here. Patients who elected non-surgical management were older and had a higher BMI. More patients in the non-surgical group were insured by Medicare and were on chronic anticoagulation as well. There were no differences between groups in reasons for consultation. The most common reasons for consultation were chronic pelvic pain and dysmenorrhea. Of the 158 initial telehealth consult visits, 20 of those patients elected for conservative treatment, with 4 completing an in-person follow-up encounter. 138 patients elected for surgical management, with 111 of those patients completing a follow-up visit. Of the 115 patients who returned, ultimately 3 decided on conservative treatment and 112 elected for surgical treatment. The treatment plans for the 115 patients who returned were compared. 110 patients initially elected for a surgical treatment plan and continued with the surgical treatment plan after follow-up visit, with a 99.1% concordance rate within that group. 2 of the 4 non-surgical plans remained the same, with the other 2 switching to a surgical plan. Only 1 patient's plan changed from surgical to non-surgical, and 2 of the 4 continued with the non-surgical treatment with a 50% concordance rate for the non-surgical group. Overall, 112 patients had follow-up plans that were in agreement with the initial plan for an overall concordance rate of 97.4%. Ultimately, 107 patients underwent surgery and concluded the 30-day postoperative period at time of data analysis. 2 patients had intraoperative complications. 1 was an EBL of greater than 500 and 1 with a cystotomy. 11 patients had postoperative complications to include superficial surgical site infection, deep surgical site infection, urinary tract infection, hospital readmission, and return to the operating room. Visit duration was obtained from billing and was about 30 minutes. Limitations of this study, of course, include its retrospective cohort design. Additionally, 28% of patients didn't return for a follow-up visit. It's unclear what they ultimately elected to pursue in regards of treatment. And lastly, barriers to telehealth visits weren't captured. So in conclusion, our study suggests that telehealth consultations for a minimally invasive gynecologic practice are an effective modality for safe surgical planning. I would, again, like to acknowledge these amazing individuals without whom this study would not have been completed. And I'll look forward to your questions at the end.
Thank you very much.
Our next presentation, treatment of a cesarean skull.